One thing I would like to highlight that the first transcatheter aortic valve replacement was an alternate access. It was an antegrade TAVR, followed by transfemoral retrograde TAVR done from Canadian group from Professor John Webb. These are all the accesses that are currently available. In general, we classify them as femoral, non-femoral, and non-femoral can be classified into extrathoracic non-femoral and intrathoracic non-femoral. Intrathoracic non-femoral includes transaortic and intrathoracic portion of the subclavian artery. Extrathoracic non-femoral includes transcarotid, extrathoracic portion of subclavian, transaxillary, transcaval. With this, I would like to say a very important point. It is the transfemoral TAVR that has been shown to be superior to the medical therapy. It is a transfemoral TAVR that has been shown to be equivalent to the TAVR group in the high risk, intermediate and low risk population. So what is the trend of alternate access in United States? The blue is transfemoral, it's gradually increasing. The orange, which was the transaortic, coming down. Transapical is almost gone these days. Even in the partner study, the transapical group did not show to have a equivalent effect as compared with TAVR group. TAVR did better than transapical. It is the transfemoral that did equivalent to TAVR group. So we should take all efforts to get the procedure done through transfemoral route. Other in the United States, the trend is going towards the extrathoracic non-femoral route in case an alternate access is required. So these are all the things that I would consider in selecting patients for an alternative access. First point, if the particular patient is a low risk candidate, I will definitely decline TAVR and send the patient for TAVR. We have a therapy that's existing for last 5 decades. Intermediate, discuss with the patient. High risk, yes, alternative access can be contemplated. The things that needs to be considered while selecting the alternate access is the vessel size, number 1. Number 2, the operator comfortability. Number 3, is it a post-CABG patient who has got a patent lima? Number 4, has it got a carotid disease? These are all the factors that are very imperative while selecting the alternative access. Multiple schools of protocols are available, no guidelines to suggest. In general, this is what is recommended. This is one approach from a high volume center which uses alternate access. If not femoral, they have suggested to go with transcarotid. If there is a lima, if there is no lima, transaxillary. However, transcaval is missing. Transcaval has got a shallow learning, it's a steep learning curve. Only few cases have been done across the globe. I will be discussing about, since it's a case-based discussion, going through few cases that was done by us and done when I was a fellow in Sinai. So he's a 72-year-old male, diabetic, hypertensive CAD patient, had known aortic stenosis, has got a CVA, post-CABG, 2 grafts done, details not available, had a mesh repair for umbilical hernia. He's a known PAD patient with abdominal aortic occlusion. So this is the echo of the particular patient, calcified valve with the high gradients. Angiography shows occluded LAD, small circ, patent lima. So angiography done through the left radial because of a very tight disease in the right subclavian and occluded aortic vessel. Patent lima has been documented and right is occluded, which we know from the CAT scan. This is the CT scan assessment of the particular patient. So he is surviving with a lima, so we can't take a chance of putting a left subclavian or left axillary in this particular patient. It was done way back in 2015 when transcarotid was not actually contemplated in this particular patient. Once right subclavian was not there, left subclavian has got a patent lima with which he is surviving, and the only approach available is it's transcaval. We didn't do transcaval in this patient. We went for a direct aortic implantation in this particular patient. The anatomy was feasible for a TAVR. I'm not going to the steps in general. You can appreciate a very tight on the right corner. There's a figure that shows occluded aortoileal bifurcation. The large collateral that's like a graft actually. It's a large collateral supplying the bilateral lower limb vessels. So the assessment was done for a direct transaortic. Thanks to Professor Muralidharan for allowing me to share his case. This is the surgically explored anatomy under GA TE support was done after deployment, during deployment. And the regular coplanar view was done, crossed with the AR2, thermo J-wire and exchange to regular steps of TAVR was undergone in this particular patient. And since we need a smaller access site, we selected a self-expandable Evolutar platform at that particular patient. He was doing fine. We have 5-year follow-up, 6-year follow-up in this patient. This is a patient who is 80-year-old male, multiple comorbidities. To summarize, he's got a triple vessel disease, kind of paradoxical gradient, paradoxical aortic stenosis, that is low flow, normal flow, low flow, low gradient with a normal LV function. He has a triple vessel disease, as I told initially. This is the echo of this particular patient. You can see, appreciate a significantly restricted aortic motion with the high gradients. He is on CKD and maintenance hemodialysis through a permacath inserted in the right IJV portion. This is the anatomy of the particular patient. Most of the time, if the groins are not good, we would like to take a smaller sheath, and so smallest available sheath, the valve that can go through a sheath is from self-expandable valves. So we prefer self-expandable valves in such situations when the patient has got a significant PAD that prohibits from us going from femoral side. The Edwards needed a certitude sheath. It's actually 22 French. That means you need a 7 millimeter diameter of the vessel. Many patients will not have a 7 millimeter diameter vessel. If they have it, we can go with the Edwards also. So this is the anatomy of the particular patient. He's got a decent coronary heights. We are not intended to intervene the coronaries before the procedure. Anatomy is suitable for TAVR. This is the anatomy. The eccentric calcium in the right iliac. This is and the left is actually severely diseased with a 2 millimeter diameter. So option of went with right subclavian and left subclavian. Right had a significant disease as compared with the left, and anatomically it's easier to go from left rather than right. It's a surgical procedure. We can do percutaneous also, but I would say since the experience with percutaneous is not great, we are comfortable getting a surgical procedure done. So surgical cut down was done, and we regularly use the TAVR techniques to deploy this, again, the self-expandable valve. This is the post gradient which was done before the discharge, mean gradient of 7 millimeter. This is the third patient, again a hypertensive guy, stage 4 CKD, multiple PCIs. A recent TTE showed a EF of 45% with a low flow, low gradient AS. He's planned for transcatheter aortic valve replacement using a Evolut Pro under MAC versus GA using sentinel cellular protection. We've got a good amount of calcium here, nodular. By definition, it's a severe calcium. When the patient has got a stage 4 CKD, we have a specific CT protocol. We don't go with contrast. We can go with contrast, but it increases the chance to go for dialysis. So we go for non-con CT and MRI. We amalgamate the images and get the procedure done. This is the non-con analysis, which says a reasonably good anatomy. We can also use a 3D TE for your measurements for analysis purposes. You can see a porcelain aorta. This patient has got a concentric femoral calcium both in the right and left. We thought of proceeding further through transfemoral. However, the femoral is reasonably okay. So percutaneous, if the femoral is also going to have a concentric calcium, we have a low threshold to go for a cut down rather than going for a PERC procedure. So this patient, problem is in the right common iliac origin. So this is the sentinel placement. We went through the left. This is non-main. Ultrasound fluoro-guided access was taken on the right side. A safety wire was placed from the left groin to right, and we did IVL to the right common iliac, and following which we deployed the self-expandable 29 Evolutar platform. This is the final DSA that shows preserved flow in the distal vessels. You can appreciate with the two French, with the six French system, the flow is gone down in the left. We didn't do any closure on the left side. It's only a manual pull. To conclude my talk, alternate access is still evolving. All the major trials have been done from transfemoral approach. Work hard to get the device implanted through transfemoral. Most likely we will be moving away from alternate access to a transfemoral IVL assisted in future if it is feasible, unless it is going to be a chronic total occlusion. There's no use of learning all the alternate approaches. Focus on one thing. If the volume of alternate access is not great, nothing wrong in getting a surgeon and getting his help in getting a cut down rather than a PERC. Again, I would like to conclude my talk with this saying that transfemoral is the key to success. Thank you, everyone.